There are some issues with illegal diversion of methadone. So just as someone who goes to me and gets pain medication can abuse that medicine or divert that medicine, the same thing can happen with methadone. The clinics tend not to taper the drug over time, so they establish a long-term relationship with their client. I really wouldn't call them a patient. They say there's such a high relapse rate that we don't recommend patient taper the drug. But the methadone clinic is a for-profit business that sells this drug and makes a lot of money selling the drug. So there might be an incentive to continue treating an individual rather than tapering and eventually discontinuing the methadone. I would also add that if you show up and say, I'm due for my methadone dose, but I can't afford to buy it today, they'll say, sorry, come back when you have some money. They also have a policy of keeping pregnant women on methadone, and that means when their child is born fairly quickly, they go into narcotic withdrawal. That increases a hospital stay up to 3 times what a non-addicted child would stay and almost triples the hospital cost. The other concern is if a baby develops, fertilization occurs and a baby develops in this milieu of narcotics for 9 months, we have concerns that when these kids grow up, they're not going to be normal. They're not going to have normal intellect, normal behavior. So we may be creating a whole generation of impaired individuals that, again, behaviorally may be a threat to society, as well as, again, sort of a delayed after effect of the narcotic use that increases crime and decreases productivity and has a detrimental effect on our community and our economy. I cannot find out if one of my patients is on methadone because methadone clinics are exempt from reporting to this state database INSPECT. Methadone clinics have no reporting system that I'm aware of, so it's possible for a patient to go to a methadone clinic in Louisville and a methadone clinic in Indiana, and they take one set of pills and sell the other set of pills. So there are some ongoing issues with methadone. There are, I think, about 15 methadone clinics in Indiana and about 700 in the country. And like I said, I believe this one is in the top 5 in the nation. So we are a big business when it comes to methadone in Clark County. Okay, so in closing then, what do? We educate our children about the danger of drug experimentation, drug abuse. We be vigilant to signs of addiction and abuse. We report suspected drug abuse. So, if you think, typically you know it when you see it. If you see these people coming up to the door of the house at all hours of the day and night, and there's some sort of exchange that goes on, I don't know, is that enough suspicion for a police officer to make a visit to that residence, or do you need more evidence than that? Or can anybody? I know Mr. Cash, you used to be a Jeff police officer.
Yes, you're absolutely right about that. There was one time when I was driving down the street and I saw some young boys carrying some baggies, and they were going to their house. And I thought that was really strange that young kids would have boxes of baggies in their possession. I told our detectives, and they got a warrant to go search that house, and that was a pretty good drug list. Just by them observing someone carrying an item that they normally wouldn't carry, that you would think is unusual.
So if someone calls and says there seems to be these transactions that take place at this house down at the end of the street, goes on all day, all night, they walk up to the door, they're there for a short period of time and leave again, is that enough suspicion for the police department to investigate?
It's enough for them to put a surveillance on that particular house, yes.
Okay. I think a lot of us tend to be silent when we suspect it, and we need to talk to the authorities about the concern, and then maybe that's not enough to generate a warrant, but as Mr. Cash says, then at least they can be aware of that location and start some kind of surveillance. We need to encourage drug abusers to get help. We need to secure and control any controlled substances that are prescribed to us. And again, Northern Indiana, a cancer patient had OxyContin that his grandson borrowed. The grandson was dead 2 days later because he took one dose and then while intoxicated took a second dose. So the grandfather who was dealing with cancer now was dealing with the death of his grandson because he didn't properly secure the OxyContin prescription. So, you know, the consequences of not keeping the medication secure can directly affect our family because you can't trust these kids to make the right decisions in every instance. We need to educate ourselves in general about the issue, signs and symptoms, strategies to mitigate the abuse, and that's again where the Bitter Pill website comes in handy. I think law enforcement needs to be more aggressive in their interdiction of the drug supplies and prosecution of those responsible. I'll say it again, you know, put the pusher in jail and throw away the keys. Put them in there for a long, long time. And then finally, any healthcare providers need to do more to prevent diversion through these principles that I was summarizing earlier. Any questions I can answer for you all? Yes, ma'am.
What does methadone do for an addict?
Methadone is a narcotic. It prevents narcotic withdrawal. It is long-acting, so you can get by with taking just one dose a day. It does not really make you very high like other forms of narcotics do. And so a methadone patient methadone client maybe, can continue to work and drive and be fairly functional and not appear to be intoxicated. We have had a few instances where the methadone clinic decided to increase the dose of the methadone, and in some cases they give the dose at the clinic. In the early relationship between the clinic and the client, they have to come in some cases every day to get one dose of methadone. They have on occasion increased that dose because they felt the patient or the client needed more, and then the client 15 minutes after leaving the clinic slumps over the steering wheel at the traffic light because they got too much methadone when they increased the dose. But so you can be functional, have the convenience of once a day dosing, and not really have much impairment from being on methadone. So it is a drug that seems to be ideal if you choose to treat drug addiction with chronic methadone therapy. Yes, Charlie?
Would it be helpful to make them have to play by the same rules as everyone else does and have to share that information so that in fact they can't go to multiple places? In other words, like when you go to Walgreens and get a narcotic, they get your name and information, whatever, and you can't go to another store, another Walgreens or wherever else because that's been written down. So should that not be a push we can make with our law, our senators, and also maybe so that we're not a magnet for that, so that our laws are not any more lax than those surrounding us, like Louisville, because a lot of those people are not from here.
Yes, well, methadone clinics are licensed by the federal government. They're not controlled or licensed by the state government, so we'd have to appeal to our federal legislators to try to make a difference in that. And yeah, we would like to have them to at least have a federal database that we could query as providers. The law enforcement can query it as well. And even better, the state database, because then we get the mix of the state information with what's coming out of the methadone clinics. Another thought about the inspect data is I've always advocated that we take that data and publish it, not down to specific individuals, but we ought to name the #1 Xanax city in Indiana, the #1 hydrocodone county in Indiana, because if you're going to change providers' behavior, part of it is to give them data so they can compare themselves with others. So if I find out that I'm doing half the colonoscopies that the other providers in the community are doing, I'm going to be more likely to order the colonoscopies because I'm aware that I'm below the standard or below the average for the community. If a physician or let's say a chiropractor finds out that they're prescribing 3 times as much pain medicine as the average chiropractor, they're likely to alter their behavior. But we don't have that data, we don't have that available to us. So I can't even tell you how my controlled substances prescribing is compared to an average for other internists or other physicians in Clark County, because that data is just not being released. So, do it anonymously, except that you could give a report to the individual so that they know what their particular data is and allow them to compare themselves to their peers. And again, that's how you can change behavior. Yes, sir.
What kind of training do the people that distribute methadone, like the one we have in Park County, what kind of training are they required to have?
Well, they have a medical director. They operate under approved protocols. The medical director typically is off-site. He's available or she's available by phone if any questions come up. They have a pharmacist, at least a pharmacist on site, and I think nurses and, of course, a lot of clerical people to intake individuals and set up appointments and such. Yes.
You've indicated that you and most everybody in the medical profession has a state office that can make inquiries to about a person taking certain prescriptions.
Yeah, inspect.
Does business have that same access, or is there a thing, they can think they got a problem, call the police and get out, whatever?
Healthcare providers, law enforcement, the pharmacies, I think, can query, inspect, but the beyond that, some of the policy makers, our committee, we actually, this Controlled Substance Advisory Committee that I chaired, we would review reports and have names of patients and providers, which we were bound to keep confidential. Some of the state legislature and state legislative staff could see the data anonymously, but those would be the types of situations where the information could be used. But they've, again, kept a lot of stuff under wrap. And so the #1 prescribed and abused pain medicine is hydrocodone. The #1 prescribed and abused sedative type medication is Xanax. And as I said, name names as far as communities, and then the providers in those communities might become more sensitive to the fact that they're the Xanax capital of Indiana, or the top hydrocodone county in Indiana, may make an impact on the prescribing. Yes, ma'am.
The place that was on Maple Street where McIntyre's grocery used to be, they finally closed it down.
Yes.
Now, was that a meth clinic, or was that just a place that sold drugs?
I guess it could be best described as a pill mill. It was owned by I believe a nurse from Kentucky. As Kentucky laws got stricter, they moved north, where they perceived that Indiana law was not quite as tight and restrictive. And a lot of unsavory types came into the city. A lot of people from out of state came in. I'm not quite sure how they got the word. I guess there's a network where people share the information of where the best pill doctors are. But with little or no exam, large numbers, physical exam and history, large numbers of pills were prescribed for these supposed chronic pain patients. And some of them probably were chronic pain patients, but certainly others were drug seekers looking for a source of medication that they could use themselves as well as sell to, pay the bills. Instead of a job, they collect these pills and sell them for $20 a piece or $25 a piece. It's pretty amazing.
Any other questions?
Thank you all.